Now, the bottom line is, we likely do significantly underappreciate how much young people are struggling. And that is very much to our society's detriment, because we really have an opportunity when people are young to change their trajectory. And what happens in childhood, what happens in adolescence, and then young adulthood, of course, you would know, determines the trajectory of the rest of your life. And the second thing is that the solution is challenging because we really don't know what the ultimate causes are well enough to intervene. But we obviously are not doing things right presently, and we need to do things differently. What's hard to know is what exactly we ought to do differently and where we ought to invest the money. This is an infographic from the Canadian Institute for Health Information, which we talk about in hospitals as CIHI. It's a wonderful national, so housed at the federal level, clearinghouse for healthcare information. And this is an infographic that they have right on their website that describes the state of affairs in simplest possible terms. And I'll talk about that. But what's also really, really important, and this theme will arise again and again, is part of the reason I believe your hands went up to say things are getting worse is because of the mass media. And that is a problem. So, mass media reports on findings that are of great and sensational interest to them. And I am not going to be Trumpian and say there's fake news, but I am going to tell you that media publishes, puts out stuff that gets eyeballs and clicks. And a dire story gets clicks. And the less dire news, no clicks. So you always want to rely on information that's been carefully synthesized by someone, by experts, to say, okay, it's always going to be possible to get a finding that says problem X is getting worse. It's harder to find a study that says problem X is getting better, because those findings tend to languish. They don't get published, and when they do get published, they don't get very much traction. So that's why I always prefer to think about what source can I go to that's going to help me put together a lot of information that's out there, not just cherry pick a finding to make a specific point. So this slide tells us that between 10 and 20% of Canadian children and youth will develop a mental disorder. And then there's this kind of scroll-looking thing it's not hidden, it's just not at the top. It says studies show that the prevalence of mental disorders among children and youth is unchanged over time. It is unchanged over time. This is truth. But then look, it's on my left, your left, I think. These two paths that diverge. So one says 75 increase in emergency department visits and 65% increase in hospitalization. That is also truth. And that shows that our response to the unchanging prevalence of mental disorders in children and youth is changing. We are now responding to it by bringing young people for help. This is a good thing. So the message is mixed in a way. There's more need than ever, and of course, if you have these massive increases, this is from 2006 to 2007, the system has to respond to that. It's going to be more costly. People may wait longer, but it's us kind of catching up with, wait, these kids are struggling and I need to bring them for help. I need to sort of do something about it. So that would be a good thing. And it's something that we think of in the field as the result of stigma busting, that we have gotten our message across that health and mental health are deeply intertwined, and that you shouldn't wait, that you should respond to a young person in need and seek help for them. A counterpoint to what I just said, this is that thing, it's truth. Please don't mistake me. this is a snapshot of Hamilton that was released only about 11 days ago, that was done in our city about youth and child mental health. And here's the headline, this is the CDC, shows troubling trends for youth mental health in Hamilton, higher rates of poor mental health and hospitalization for mood disorders. So that, again, it's not inconsistent with what Kai is saying. This is showing us that in our city too, there's this pattern of rising need and people describing themselves as needing support and help, as do their families. So that makes sense. Now, next slide. The study finds 1 in 5 Ontario children have mental health problems, same as 30 years ago. What? What are you supposed to make of that? Can that be? Yes, it can be, because it reflects the theme that I already explained. When we get more scientific about asking people, what specific symptoms and functional impairments do you have, we see a very rock-solid, steady line of response to those kinds of questions. A little bit of the pattern is changing, but this Hamilton Health Snapshot focuses more on how people are portraying and describing their needs. And they're accurately now saying this is an important need, even though the underlying problem is pretty rock solid and not on the increase. This is pictured our Michael Boyle, Kathy Georgiadis. Michael is a member of the Order of Canada, one of our most distinguished professors in the city and at McMaster. He pioneered this same study in 1983, and it was just recently done again. This is from 2019. And so this is really great data. As they did in 1983, they got over 10,000 children responses to this, which is incredibly rare. Because it's actually really hard to get into the school system, and it's hard to get into children and youth to ask them these questions. But Michael and Kathy and their team are great at doing this. So this is the kind of data that again, I can trust, I can rely on this data. And it tells us, buried a little bit further in the story is actually the same pattern, that despite the steadiness of the actual underlying conditions, the pattern of help seeking and demand for help has changed drastically in the last 30 years. So in 1983, even though it was 1 in 5 kids who were struggling, nobody thought that was such a big deal. They thought, well, it'll work its way out or whatever. We may react to it later, but no need to panic. Today, that pattern doesn't exist. People are noticing, and people are saying, obviously we need to get in here and we need to address this, and we need to come up with some potential strategies. So this then is another infographic. This is from the Mental Health Commission of Canada. And again, my suggestion is to when you're trying to respond to this kind of specifically health information, is go a little bit deeper than the media headline and think about who the source is. And it's hard for me to give you a definitive list of like, oh, I would believe Kai. I guess I would believe the New England Journal of Medicine. I would believe in, there's a bunch, but again, it's sort of hard to say. But you have to know what the source material is. And increasingly, even people like me who read this kind of data a lot, find ourselves wishing for aggregated or synthesized information. So I tend to look for these days on important topics, what are called meta-analyses or mega-analyses, where lots of studies have been put together to give me a more general picture so that I don't end up just noticing the one study that says something is true, but I never see the other study that goes in the other direction. So again, this is all synthesized data that I can believe in and you can believe in, and it's worrying. So again, it tells us the same thing that we've already heard. 1 in 5 have a diagnosable mental illness. 75% of children and youth do not receive treatment. That's also true in the Ontario context. It's slightly different. It was 2/3 in the recent Ontario Mike Boyle Georgiadis study who weren't receiving treatment, only 1/3 were. Suicide is the #1 cause of non-accidental death among youth. And as many as 173,000 Canadian kids will try to take their own lives this year. And almost 90% of those who die by suicide in this age bracket have a mental illness. And every year we lose 762 young Canadians to suicide, 2 every day. And it certainly happens in this city. We're absolutely not immune. So, one thing that the field agrees on, and you could have picked a different speaker today who would have sounded maybe a different note, who would have told you it's getting much worse. If Mike Boyle was here, and I'm not Mike Boyle, he's a sober scientist, he'd say, it's steady, not changing. So no need to panic. So you can sound different messages depending on what your point might be and who you're trying to lobby. So, but this we all do agree on in the field, that the origins of mental disorders are in childhood and adolescence. That 75% of what turns into an adult mental health disorder was present before the age of 24. And left undiagnosed and unchecked, these disorders can have a worsening course for decades. And when I entered the field, it was about 20 years ago that I became a professional psychologist. And as the bio said, I worked in mood disorders. And we would very often meet people with, for example, bipolar disorder, who were into their late 20s and early 30s. But on history, it was pretty obvious that this had started quite a while ago. And the person wasn't sure how to respond, people around them weren't sure how to respond. So a lot of not great things had happened during their low phases and during their manic phases. And it was easy for us to imagine that had we met these people earlier in their lifespan, we could have caught this earlier, we could have treated it faster, we could have kind of bent the curve on what was going to happen to them and maybe saved them from some of the most difficult outcomes. And so we still think that's true, but the unfortunate part of my next message is that we don't seem to know how to do that. It seems tantalizing and tempting to say that if we can catch these things before late adolescence and into early adulthood, then we can change the trajectory. That has proven to be more tempting than it is easy. So it makes sense, we should do it, but it's been difficult for us to get where we need to get, just with that. I also wanted to talk about vaping and opioids, because that will be on your mind, as it should be. These are two things that, Mike Boyle 30 years ago, in 1983, wouldn't have been asking about in the survey. These things really didn't exist. So let's talk about that. So this is a recent Canadian study. This is one of those things I shouldn't do, which is to cherry pick something. But I think it's pretty consistent with the pattern around the world, certainly in the US. So a rise of 74% in 1 year of young people vaping, from 8.4% of youth to 14.6%. So again, imagine you're the media people, you're gonna say 74% more kids are vaping. You're not gonna say 14.6% of youth are vaping, because that's not as many eyeballs. But it's accurate. It's a staggering year-on-year type of increase. And youth smoking rates are dropping, and that is fantastic. And what is sort of so sad about this is that, we reached this point when we had finally licked youth smoking. Like, it is crashing. Even that Hamilton snapshot here, which just came out 11 days ago, it's kind of near the bottom. It basically says smoking is decreasing and we're not as worried about that. And yet somehow that dreaded drug of nicotine makes a comeback in the form of vaping. And if somebody said to me, Dr. Bieling, help me choose between cigarette smoking and vaping. And I'd say neither of those, or maybe nicotine gum. And they say, no, it's only those two choices. Of course I have to say vaping. Cigarettes are so much worse as a delivery mechanism for nicotine than vaping would be. But the real answer is neither, and we need to do more now, I think, to prevent kids from beginning to vape. And then, of course, opioids. Terrifying stuff going on out there, I understand that. So opioids and fentanyl and carfentanil are the ones that we're most worried about and talking about, can be rapidly lethal. And it's important to sort of say why. Fentanyl and carfentanil are not any different than the opioids that we already knew. It's just that the specific molecule is very, very, very potent and is almost potent enough that you can't see the grains of it that might arrest your breathing. And so when people are creating batches of drugs to sell, they're tempted to put in fentanyl because it's very, very potent, but they don't have the technology. I'm not suggesting they should, but they have no way of knowing whether they're cutting in the right stuff. It's as if in a single coffee bean, there's enough for an entire jug of coffee. That's the problem. And I am not sanguine about it. I'm incredibly worried about the opioid crisis, but if you do some careful looking, it has not reached youth in the way that some other drugs have. And the #1 drug of abuse we still worry about in young people is, as it was decades ago, it's alcohol. So this chart I love. It's slightly complicated, but not really, I guess. This tells you the different sort of disease categories and when they have the most impact in life. So let's look at the end first, because it's sort of easier to picture. This slightly greeny color is neurological and sense difficulties. That would be things like, including dementias. And you can see there that by the time you get to 70 and 80, that's, as we would think, that's a high-risk disease to have there. It's virtually non-existent when you go back to the circle spot where you're age 20. But look at mental disorders. Up to age 10, we're sort of, they're present in young-ish kids. But during adolescence and into young adulthood, there's this massive spike. And then it actually goes down again after that. And in fact, it diminishes with age. There's a good news story with regard to mental disorders. If you don't have it by the time you're 30, it starts to sort of, the risk begins to change dramatically that something will develop. But that too, that circle, is where the opportunity lies, is getting to people early, intervening early, and providing services at that sort of critical juncture. So we know that adolescence and young adulthood is a really critical developmental period. And this shouldn't be new. All of you are teenagers. You remember, it is an incredibly fraught, challenging time in which our identities are being created. We cross all kinds of developmental thresholds and hurdles. Our friends are incredibly important to us. Our families are incredibly important to us. And we now know, again, it shouldn't be surprising that when I went through school, not that long ago now, basically 30 years ago, I'm receiving my basic training. I was told that really the brain is fully grown by the time you're an adolescent. And by weight, sure. But we now know that there's incredible brain formation that continues through late adolescence and even into your 20s. And again, just introspect a little bit and reflect that, of course that makes sense. There were things that you did, and maybe I'm speaking to the young gentleman now. There are things that you were willing to do when you were 21 that by the time you were 28 seemed incredibly foolhardy. And you think, well, I learned from that experience, and perhaps you did. But now I can also be quite sure that your brain changed substantially from the time you were 21 to 28, and that helped you curtail some of that stuff that was sort of putting you at risk. And we know that, so adolescence and puberty is happening earlier and earlier and earlier. That itself is a whole talk on why that might be going on. We don't know, but that bottom age for puberty is going lower and lower and lower. And as I said, all these key developmental tasks are along the way. The age range that we're focused on, for example, at St. Joe's in our Youth Wellness Center, is 17 to 25. A 17-year-old is still in school, working out who their friends are, working out what their future is. But of course, by 25, you can be married, you can have a young family by age 25. Those 8 or 9 years, a huge amount of stuff is going on that's really very, very determining for the rest of your life. We are spending more and more and more money on healthcare. In Ontario, just over 40 cents of every tax dollar goes to healthcare. And healthcare is always threatening to eat up even more of that. And as somebody who works in the hospital, I'm very sensitive about that. We're trying to limit the damage to the wallets of Ontarians. But since 1975, and this was data up to 2009, but it just kept going. This is in 1997 dollars to control for the different value of the dollar at different times. We are just spending more and more and more. And what are we getting? Well, this is child mortality data from 1950 until 2015 across the world. And we're getting quite a bit. Now, North America is at the bottom in red. Its curve looks pretty modest. But in the developing world, as we put more resources into these problems, we can crash the impact of diseases on young people, which is great. So we are getting our value in certain disease categories. And I would tell you that the reason that we get value there is because we fully understood what I think it was the pathogenesis of the disease. We've worked out it's a virus. We've worked out it's a bug. We've worked out you can immunize people for it. Once we figure out the exact mechanisms, it's not so hard to put into place all the things we need to prevent something from happening in the first place. So generally, I say we can be satisfied that the money we spend in our healthcare settings is delivering us the kind of results that we want. Sadly, child and youth mental health is an exception. What we see, as you know from the prevalence line, is a flat trajectory. In other words, why is it still 1 in 5? Why don't we see these decreasing slopes when we're devoting time and energy and money to treating young people with mental health issues? So there's no clear answer, as I alluded to. We know that there are risk factors for sure, social disadvantages, and one thing we can dismiss more or less outright is that there are no particular parenting practices that are like an absolute no-go. Times change with regard to what parenting advice is the most popular, right? There was Dr. Spock in the 60s. Sigmund Freud and many of his followers had very specific notions about what a parent should and shouldn't do with children. We can actually pretty much dismiss those. There's a broad range of what can work with children and what I would consider really good sort of parenting. But there are also points at which we can say, that's not good parenting, that's not good child rearing. And social determinants of health like poverty have a lot to do with that. I want to return to severe long-term stress and trauma because sadly Canada has an example where we did a sort of naturalistic experiment that was awful and showed us what not to do ever again. And then of course family history. Many of the mental disorders we know about do have a genetic component. They're passed from parents to children. Also, some people would say that, well, maybe it's a flat line, but we're helping some people, but there are also factors that are increasing that are making it harder, making it worse. So some people who get service are improving, but more people are arriving at the service because there's some pressure out there that's producing more problems. So what are they? Well, again, our friends in the media can tell us that it's what I've put in air quotes there as modernity. So it's social media, it's our phones, it's our limited attention spans. And you know, a good example would be that while we've done a lot in schools to reduce frank bullying, we also have our kids, most of them, on Snapchat, not Facebook, because that's for old folks, but they're on Snapchat, and they can bully each other 24/7, so there's no rest, right? People can go back and forth with you on Instagram and say all kinds of things 24/7. So is it one of those modernity factors that's causing this lack of progress, right, that's getting us stuck? This is a very difficult notion to evaluate. Reduction in stigma, that is definitely happening. So people are coming for help because they recognize the need. We want that. We do not want to go back to the era in which people were not taking these things seriously. Parenting in schools. It's brought up as a factor. I've got to tell you, I'm not a big believer that there's something specifically different that parents are doing today that somehow disadvantages our children with regard to mental health and addiction problems in the future. But I'm just sharing with you, it is a hypothesis. And finally, just to go back to bullying, because it's interesting, and you all have young people in your lives, and so do I. We had a tragic death of a student at Winston Churchill in this city not very long ago. I might tell you, and you could argue back, that stabbing somebody with a knife is much more than bullying. But of course it made us all stop to think, wait, are we doing enough in our schools around bullying? I don't think I'm going to convince you that we are or we aren't. But I can tell you that my daughter, who just started high school, but I can tell you that her experience starting high school is vastly different than mine. I was initiated by a grade 12 student in a way that I can barely describe to you, and every day, this is BC, so you were in grade 8, you know, they played pinball with us off the lockers, the older boys in particular. I describe these things to her, and she looks at me like, that doesn't go on, it would never be let go on by the powers that be. This is just unheard of. So we're obviously doing something in the right direction, but then these specific cases happen that make us question, you know, is that enough? Are we on the right track? And we obviously haven't stamped it out completely, but we're making good efforts. And it's hard to do really great research in this area. You can totally get that, I think, that you can't take children at birth and separate them and give them one type of parenting, you know, randomly, and then another set, oh, you'll go to those parents. This is Mengele stuff that nobody wants to do or can do. So it's incredibly hard to get really good science, because we know that the younger you are, the more sort of entangled all the variables are with family and who's the parent. And you know, in parenting research, we know a ton about moms. We know nothing really substantial about fathers. Sorry, gentlemen, because fathers don't seem to want to or contribute enough variability for us to really study dads. So, gentlemen, get going. Lean in when it comes to parenting, I think. And you need a long period of time, right, to study these things. I mean, Mike Boyle and Georgiadis, so they did their first survey 30 years ago. That was just a snapshot. It took them another 30 years to get back into schools to do it again, because the politics of this are so gigantic. And ethics are ever present when you're trying to do you know, significant scientific work in children and youth. I'm not saying that's bad. I think that's a good thing, but it makes it hard. And to get back to the dark natural experiment in Canadian history, maybe you would have guessed I'm referring, of course, to residential schools. Of course, ending only by the 1970s, and for reasons that at the time, I guess, seemed okay to the powers that be, that somehow the best way forward was to integrate Indigenous people into Canadian society by scooping them up from their parents and bringing them to distant locations and depriving them of so much. So we know that that generation of kids who survived that has struggled mightily and continues to struggle. And that it's not just them, it's their kids, and now their kids' kids who continue to struggle thanks to that horrible experience. So when I say that, you know, your early life circumstances and parenting don't matter, I mean they don't matter in the nuances, but in the big thing of you don't get to speak your own language. You're not well fed or well cared for. There's no one who really loves you, and there's people who, at a moment's notice, are willing to abuse you in all kinds of unimaginable ways. That, of course, creates mental disorder in children and young adults. So it's where is that line that I think is more difficult for us to figure out exactly. So, as you go out in the world, good luck to you in figuring this all out. Here's two headlines from not quite the same day, but the same week. One, social media is not to blame for children's poor mental health. Day later, frequent social media use bad for teen-year-olds' mental health. Study. Okay, go figure. I'm going to tell you that I like the top left because it does come from the UK. The other one's a Canadian study. But the UK one was a very expensive study at a high level population that was looking at all kinds of factors, whereas the other one was sort of looking at a much smaller sample and just isolating social media. And what the UK report actually found, because it's nice to get into the details if you can, is that there was a correlation between social media usage and less good mental health, but once you accounted for other factors, including social determinants of health, it disappeared. And so that makes some sense, and it basically means if you're a terrific parent and you're supportive and loving of your kids, you don't have to ban them from Snapchat. They'll be okay with it, but there are kids who are growing up in less great circumstances, who don't experience the love and support, and for them, Snapchat doesn't help, it probably makes it worse. But see, I think you knew that before you even got here today. What are we going to do? Because if we have this flat line and we want to not have the flat line, we want to reduce prevalence and incidence, we want people to come for help and then get good help, what are we going to do? Well, what we're doing is not great, it's not terrible, but we could do a lot better. One thing that gets in the way that's been interesting in my career at St. Joe's is that there are actually two different ministries involved in this dilemma in Ontario. So there's a ministry that does child youth mental health, the Ministry of Children and Youth, that basically looks after young people to age 18. And on their 18th birthday, that ministry says, not us, and it goes over to the Ministry of Health, hospitals, so that's us. That has meant that there's an interesting tug of war and push-pull and a real discontinuity, because it can be the case that if you're a young person struggling with a mental illness, up to your 18th birthday, you have wraparound care that includes your family, and that's what you're used to. And then the service provider says, ooh, you're turning 18. They don't do it quite this way, they try to think ahead. But once you're 18, you can't come here anymore. We can't see your family anymore. And now my hospital treats that 18-year-old as a grown adult and probably doesn't have a place for their family. There's sort of no family support or therapy suddenly because we're treating individual adults. And frankly, there's some reason for that, which is that the adults that we treat who are in their 30s and 40s, of course, aren't necessarily going to be bringing their families. It won't matter as much. So we've got this sad break in care right at this most vulnerable point. And 18 is just tough. When you think about it, that's also when age of majority, you're graduating high school, you move to university, it's really not a good fit. But people are trying to fill in this gap. So while we might not know the ultimate causes, this is a cool thing. This is the Mental Health Commission of Canada, who developed a young adult youth mental health strategy that was like this white paper, you know, written in very grown-up sorts of ways. And then they said, oh, let's rewrite this report in the language of youth. So this is what the cover page of the youth version of the report looks like. So you can tell right away that it has a more informal, sort of youthful flavor. And it's a great resource to see on the web. And what it purports to do is create kind of a roadmap for what we ought to have in place. And in Hamilton, we're extremely lucky. Of course, I'm here to somewhat advance the reputation of St. Joseph's Healthcare. But I also can tell you that the Children and Youth Program at Hamilton Health Sciences at the Ron Joyce Center is an amazing program with really gifted clinicians. The trick is not so much getting this 5 different levels of care in place in an urban environment. The trick would be Pan-Canadian, Northern Ontario to get all these sorts of systems in place. So we absolutely need a community response. We need to probably do more with family physicians who are the gateway for lots of services in Ontario that are sort of more specialized. Universal public community resources is level 1. 2 is the primary response from your GP, and by the way, I have no problem if these slides are printed and made available. Level 3 is mental health and addiction service response assessment and treatment. So now we're getting to more specialized services. Number 4 is specialist acute inpatient services. So that's when we're hospitalizing young people, like for depression, and we do have a service like that at the Children's Hospital at Mumsy. And in highly specialized inpatient residential settings, those are often reserved for young people who have significant developmental delays from an early age and can't live in a home environment and have to live in a more institutional setting. So that layered approach is probably the one that we need. It's just, where's the money? How are we going to get to it? How are we going to reform? In Hamilton, I'd say we're incredibly lucky. This is the Twitter page of our Youth Wellness Center. It's on Main Street, right downtown. We serve young people from the ages of 17 to 25 there. We've arranged that age bracket with our partners at the Children's Hospital so that we're not crossing those kinds of boundaries with them. And they work very closely with us to help transition kids who are aging out, as they say, from children's services into adult services. It does not look like your typical hospital setting or clinic because it's co-designed with youth, because we need to present a very welcoming face. That little washroom sign, which is multi-gendered, was in its time the most retweeted image that St. Joseph's ever put up. Because surprisingly, lots of agencies are grappling with how to signal that a washroom is okay for anybody. Because you know what it used to be, a little mannequin, a little womanikin, is that what that is? And we're the only place in the hospital that's allowed to have a Netflix subscription. So that's a bigger deal than you'd think. And this is, we're not alone. This is happening around the world. So Origin is in Australia. They've recognized the need to merge the child and the young adult sector. It's happening in Ireland. It's happening in the United States, the UK. So lots of people are recognizing this. We just don't know yet what the impact of these new youth-based services will be. And in Ontario, we're doing the same thing, though not that any of us can help this situation. Unfortunately, in Toronto and in Ottawa and even in London, a lot of it is based on charitable giving rather than funded from hard ministry dollars. And that can be a problem because it can be hard to sustain giving to keep a clinical service open. Okay, you want to ask questions. I want to get there with you. The bottom line, it's a multifaceted problem. The solution to this will not be simple, and please resist really simplistic explanations of it's just this. I doubt it. It's difficult not to panic, but fear and blame won't be helpful to solving the problem. And again, I think the media doesn't help me with that case because they sometimes say that the sky is falling. People start blaming. Think of what happened at Winston Churchill. I don't know whether it's the school's fault, but you can see the fingers going there. Is that helpful, or do we need to sit down as a community to figure out what went wrong here and everybody take a slice of responsibility for this? You should feel good that Ontario Health, which is the reformation of the LHINs and the ministry into this new entity that we know not yet what it is, but we have submitted in our Hamilton application a priority population is children and youth with mental health conditions. So that will undoubtedly begin to turn existing funding at least more into this area than it is right now. And it's nice that we declared it a priority because I agree that it is. We definitely have to innovate, break down barriers, and this can't be more important, co-design these things with young people. If a bunch of adults sit around and say this is what kids need and want, they're not even going to show up. So we've got to get them in the door, we've got to connect them. So it's great that they're putting their hand up to say this is a problem and their parents are helping, but we've got to do other things. And a great example, and again, much harder to get to than you could have imagined in a hospital. At our Youth Wellness Center, you can self-refer. You can go online and say, I need help. You don't need a doctor's signature anywhere to come in and see us. And that's a big leap forward because it allows young people to not necessarily need to tell their family doctor or even their family. They can just signal to us, I need help, I want to come. Not that we don't accept doctor's referrals, we do, but we just do both. And then finally, I think we're going to have to measure this stuff carefully because it's such a complicated area, and to know where our investments are paying off, like what is bending this trajectory versus not, also requires an overlay of careful research so that we don't end up saying, well, something worked, we're seeing something work, but we don't know what it is. And if we don't know what it is, then we can't replicate it in the next initiative that we get into. And that's it. Thank you.